Okay, we're going to start doing our thoracic manipulation now. I'm going to show you 3 moves, and then we're going to break out and practice them. Then we'll do another 2 or 3, and we'll keep moving through the list like that. The first adjustment is prone hypothenar transverse manipulation. I hope that you took to heart some of the stuff we did last week in terms of psychomotor practice, because that's going to be key in really developing and improving your adjustive skills. This first adjustment is great for moderately stiff to stiffer patients, and we're going to use a bilateral hypothenar, right, mid-thoracic spine. It's going to be mainly for extension. It really depends on how you load the patient up. Most patients who need extension in the thoracic spine are at a disadvantage when you lie them prone because you're flexing them more. So one way to alleviate that problem from like T4 to T8, T9 is to take their arms and tuck them underneath their pockets. I do this all the time in practice when I'm adjusting patients prone. So this first adjustment is again a hypothenar transverse contact. So there's the contact. The doctor is going to lean over the contact. It's going to be a triceps twitch, right? Triceps and pec twitch. It's a very gentle adjustment. You're not really loading it up that much. Just enough to take out the tissue slack, right? You're over the contact, and then you're going to use the twitch to create the adjustment. Right? So it's not a heavy-duty adjustment. It's for a patient who, again, moderately stiff to stiffer, and you don't want to be that forceful. Right? So you're just going to take out the slack and then use that twitch to do the adjustment. The next adjustment is the prone thenar pad transverse. Now for that, you are going to use your thenar pads, right? You're going to lift up a little bit on the outside of the hand so that you can concentrate the contact onto the thenars. But this certainly is a body thrust, right? You're not going to use your triceps, your pecs at all for this. You're basically, again, going to get in the center, right? And you're going to use that falling, that lunging maneuver to do the adjustment, all right? The last one I want to show you before we break out is the crossed pisiforms, crossed hypothenars at 90 degrees. This is the same drill that we did last week, right, where you're kind of lowering your hips down, right? You're making the contact so that you end up in the same area, right? So you start with a tissue pull, kind of wind your contact onto the tissue. So it looks like this, just like that. And then I take my weight from my legs and I load it onto my hands. So now all the weight's on my feet, and I load the weight onto my hands. What I'm going to do is let my pelvis drop down, and I'm going to use that force to deliver the adjustment. It doesn't come from the arms, it comes strictly from the legs. Now I will tell you that I use this technique, a variation of this, in many patients who are very stiff, hyperkyphotic, need extension, a lot of degeneration, not good candidates for high velocity, low amplitude manipulation. I'll do it as a mobilization. So I'm just leaning in and kind of just getting a sense of how flexible it is. I'll often do this on my decompression table. So I'm opening the patient up while they're getting that posterior to anterior movement in there. I'll switch hands, right, and I'll go in the other direction as well. And just move up and down. And on these patients, I'm lowering my body weight. I'm still not thrusting with my arms, but I'm just being very gentle in the delivery. I'm not adding a definitive drop. And that's a great mobilization for patients who need thoracic spine extension. So this next adjustment is one you're definitely going to want to have to utilize at the appropriate time. It's a hypothenar drop thoracic manipulation. We're going to use a hypothenar contact, but now we're not going to use that gentle triceps twitch. We're going to use our body to kind of hammer our hypothenar contact. So this is going to be really good if you're a 125-pound doctor and you're adjusting a 275-pound patient and you want to be able to generate a good amount of force. This will be excellent for that. It can work with a bigger doctor too. You just have to learn how to control how hard you hit it with the hammer. You have control over how much of your weight you'll utilize. So again, because we're trying to use this for extension, I'm going to have you bring your arms underneath you. All right, I'm going to open you up here. Okay. Just tuck that in. And we're going to zoom in here a little bit. Okay. So there's the contact. Right. And you can intertwine. You want to make it a firm bridge. You want to make your hands stiff because you're going to be hitting them with your chest. Right? So make your hands stiff. Get in that nice one-line stance and over the table. And what you want to do is kind of like coil, and then you're going to come down with the hammer. You're going to literally fall with a certain amount of your body weight on your contact. Is it okay to perform that on you? So arms are relaxed, your hands are stiff, and you're just going to come over and hit it. Would you mind going up into a Sphinx posture? Okay. Okay, so when we did this, the prone palpation with the patient in the Sphinx posture, did anybody feel any releases while you did that? Sometimes you will. Just gentle palpation, you'll feel release. The other nice thing about this position is you're lifting the thorax off of the table, so you're not compressing the thorax. So if you have a patient who's prone to loss of bone density, rib fractures, this is a good position to adjust them in. Same thing with supine and standing adjustments later on. You diminish the compression on the thorax. So we can easily turn this palpation into an adjustment. Again, you want to deliver, you want your force delivery to be through your body weight, not through your arms. So you're just reinforcing it with your other hand. And the key is to load it up very slowly. Load the contact up very slowly and gently, and then it's just a little bit of a drop with the hips. You can kind of see that left hip drop down. You okay, Thomas? So I load it up. And just drop down. Gentle. It's a gentle adjustment. So we're going to do two general types of supine adjustments. One's a horizontal adjustment, horizontal lift. The other is vertical. What does that mean? It means that when we're doing horizontal, the patient's going to stay horizontal. When we're doing vertical, we're going to actually lift them up a little bit to create a little verticality. I don't know if that's a word, but you guys know what I mean. We're trying to get the patient upward a little bit. All right, so let's do the horizontal lift first. Again, it's gonna move the spine, however the spine is preloaded. You want your patient comfortable. And I'll see if I can zoom in on this a little bit for the camera. Okay, good. So here's the contact, right? And in this case, I'm going to use it right on the spine. The spine's going to go right in the center. If this hurts your hand, doctors, you can put some toweling in here. They make devices that can support your hand as well. I think supine adjusting is a great skill to have, but you don't want it to hurt your hand. So do whatever you have to do to kind of take the compromise off your hand. So for this adjustment, for the mid-thoracics, we're doing T4 to T8. I'm going to take my tissue pull up. And remember the drill that we did where you kind of fell on your patient for side posture, literally kind of learning how to let your body kind of fall on your patient? That's really how you want to deliver this adjustment. Again, modifying the amount of weight that you may actually put onto your patient. So I have this leg up, making it a bit easier to roll my patient. I'm going to take my contact, I'm going to find the midline, okay, right there. I'm going to take my tissue pull up, right, and then roll back onto my hand. That body weight alone, his body weight, is enough tension. All I have to do is kind of hammer it from here. Now I want to take the elbows And when I'm doing it from contralateral like this, I'll always cross the contralateral arm over the top. It's just a softer contact for him and for me. I want to bring those elbows down and or move myself up so that I don't take the elbows in my chest. Right? So as long as I pull those elbows down a little bit and move up a little bit, and that's going to put me right over my contact. So the delivery on this would be just to stay nice and relaxed and just come over and fall. Just like that, fall on my contact. That would be an example of the horizontal lift. And I can do that very nicely anywhere from like T4 to T8. So the vertical lift is really good when your patient is not really that stiff. Maybe, you know, just mildly stiff or perhaps even very flexible. Not like when you try and do a horizontal lift, your hand just buries in their back, right? So you need a little more tension. Also good, which is good for the patient who also needs flexion. Horizontal lifts work great for extension. The vertical lifts are going to give you a better platform for creating flexion. All right. So again, have the patient bend their knee. All right. When I'm doing a horizontal lift, I'll always cross over the opposite arm on top. But in this case, I'm actually going to reverse this, and I'll show you why in just a moment. I'm going to use my arm to help lift the patient up. So I want the soft part of their arm with the soft part of my arm. All right. I'm still going to use a contralateral contact. All right. We'll see if we can zoom in on this a little bit. Okay. So we start out with our hand supporting the neck, lower part of the neck and upper back. My forearm is on my patient's arm. I'm going to lean back, kind of sit back a little bit to kind of help lift the patient up. Reach underneath with the other hand. All right, there's my contact, nice tissue pull up. Again, the elbows are already in my gut, so I don't have to worry about taking them in the chest. And as I roll the patient back, I can feel the load on my hand, and I maintain that verticality of the patient. I don't let them go back to the table. I let them stay up here and then just add my thrust from there. Now, a variation of this, either with some lift or without some lift, is to add some lateral flexion to this. So the contact's the same. You can see my contact, but I'm going to push across to my right, bend my patient over the side of the contact, and then again a drop from there will create, in that case, right lateral flexion. I can also modify this to do rotation. So if I want to perform rotation, instead of making the contact in the midline with pressure on both sides of my hand, I'm going to concentrate the pressure, in this case, on the left side of the spine to create right rotation. Right. So it'll look like this. I'm going to roll you towards me. I'm going to just expose that area. Here's the midline. This part of my hand right here is on the left side of his spine. I take a tissue pull up. You can see that my thenar is not actually on my patient at this point. As I roll the patient back, I tuck the elbows down a little bit, put them in my gut. And as I roll back, right here is where my fingers start to engage. And I'll do my drop right from this inclined position. My patient's at a 45-degree angle. And from there, I'll just drop onto it, and that will create rotation. So you can modify these techniques in a variety of ways to create different types of movement.